And I now request Professor K. Srinath Reddy to deliver the B.G. Verghese Memorial Lecture. 2 minutes, I'll just introduce you. You need no introduction, but we shall do it. Professor Srinath Reddy is President, Public Health Foundation of India. He formerly headed the Department of Cardiology at the All India Institute of Medical Sciences, New Delhi. Under his leadership, PHFI has established 5 Indian institutes of public health to advance multidisciplinary public health education, research, health technologies, and implementation support of strengthening health systems. He served as the first Bernard Lawn Visiting Professor of Cardiovascular Health at the Harvard School of Public Health between 2009 and 2013, and is presently an adjunct professor at Harvard and Emory Universities. He's the first Indian to be elected to the National Academy of Medicine, USA, and is a Padma Bhushan awardee. Over to you, Dr. Reddy. We're looking forward to listening to you today.
Mr. Khare, Ms. Basu, Arifaji, distinguished leaders of the Indian media, luminaries in the audience, ladies and gentlemen. It's indeed a great honor to have been asked to join a galaxy of speakers who have preceded me to deliver the B.G. Verghese Memorial Lecture. Indeed, to be part of this gathering, where both the oration and the award are a celebration of journalism of conscience and courage. Mr. Verghese had indeed influenced me as a young reader, and I was one among the many who were informed and inspired by him, as he epitomized a tradition of journalism where facts are assembled with integrity, analyzed with objectivity, communicated with conviction and clarity, and there is no compromise on principles and no collusion with powerful interests. And even during the dark days of COVID, sections of the media shone a bright torch on the fault lines of our health and social systems. And some of them have been reflected in the writings of the Chameli Devi awardee today. And it is perhaps the virus which unwittingly earned me this honor today, since health has never, as before, been brought to the center stage of attention, both in the policymaker realm as well as in the media attention. Therefore, I will start with where I've been asked to start. What are the lessons that we can draw from COVID, both for the health and the social systems? Firstly, we recognize that we need an efficient, equitable, and empathetic health system functioning reliably at all times to provide a swift, strong, and sustained response to any public health emergency. You cannot have a health system suddenly picking up speed and running briskly if it has been limping on one leg. And therefore, when challenged with a public health emergency, you do need a system that is already well functioning. The second, of course, is that we need a health system that does not have a tunnel vision. And we cannot have a health system which, when preoccupied with the public health emergency, is incapable of addressing other felt needs of the society, whether it's antenatal care, routine vaccination of children, treatment of other health conditions, whether it's hypertension or diabetes, or resulting in postponement of surgeries which are necessary. And therefore, we do require also to learn what kind of a health system we must configure. We need a strong primary health care system. Now, this may be surprising because the images that filled The media, the visual media in particular, during COVID, were those of intensive care units, screeching ambulances, and ventilators. But we recognize that ultimately it is the primary healthcare system which provides the principal defense against a public health emergency, and the supportive services are coming from advanced care institutions. To explain why, in terms of COVID, early detection of cases and of persons who were exposed to them, prompt testing, contact tracing, triage for home care and hospital care, home care support and supervision, management of long COVID, the consequences of symptoms persisting well beyond the initial infection, vaccination, health education on how to protect oneself personally, combating fear and stigma in society, providing health education for all of these elements are part and parcel of well-functioning primary healthcare systems. And we saw that this did not happen as effectively, and particularly the relative absence of an organized primary healthcare system in our urban areas really proved costly when the virus made its entry principally through the urban portals of international airports. Then we also recognize that we need to build domestic capacity, whether it was test kits or personal protection equipment, vaccines or medicines. We recognize that we need to build public sector and private sector capacity, and we cannot depend upon fairly unreliable supply chains which are operating globally. And we also recognize that we need to build capacity in the public sector too, which has been long neglected. For example, in the pharmaceutical sector, we know that we can justifiably take pride in the way our pharmaceutical sector is developed, whether it's for drugs and vaccines. But we also know that when it comes to the usages of compulsory licensing when necessary, and for essential price controls, for affordable pricing of medicines, the private sector may not necessarily step up to the task. And therefore, you do need a very strong public sector presence, even if we have to draw upon the private sector strengths. We also know that we have to build public health capacity. Our public health expertise has been very minimal, whether it is in epidemiology or in terms of actually ensuring contact tracing. It is unpardonable that the task of contact tracing is left to the policemen rather than to train public health workers who are specifically trained for that job. So we do require a public health capacity which is multi-layered and multi-skilled. And even for health care, we need a stronger health workforce. We are already short in terms of our numbers of doctors and nurses and other components of our health workforce. And when you're challenged with a public health emergency, either because of their becoming ill or exhausted, there is going to be an attrition, and you cannot really have it unless you have built in a certain degree of expansile capacity, or a slack, as we can call it. And that does not exist. So we also need to train auxiliaries, train community volunteers, and we need to make sure that we have systems on alert and supplies on the ready in case a public health emergency strikes at us. So how is our health system delivering? How healthy is India? Let me read out a few key health indicators. We have actually made substantial progress. In 1990, our infant mortality rate was 88 per 1,000 live births. In 2020, it is 30, almost reduced to a third of what it was. Our maternal mortality ratio was, in 1990, 556 per 100,000 live births. In 2018, it came down to 213, almost to a fifth. Certainly, we can be proud, but the progress was extremely uneven across various states. If you look at infant mortality rate, a child born in Kerala has a much better chance of survival, where there is an infant mortality rate of 6 per 1,000, as compared to Madhya Pradesh, where the infant mortality rate is 46 per 1,000. Almost 8-fold difference in the same country. And when we go to international comparisons, we recognize that despite our greater pace of economic growth, we are not comparing ourselves very well with many of our South Asian neighbors or with many other countries in our economic bracket with whom we are bracketed in the BRICS grouping. For example, if you look at life expectancy in terms of years from birth, in India it's 69.2, Sri Lanka 77, Bangladesh 72, China 76.5. Nepal has a higher life expectancy than ours. If you look at infant mortality rate, India 30, Sri Lanka 6, Bangladesh 25, and China 7.4. If you look at child nutrition, then even in the latest National Family Health Survey that we had in 2019 to 2021, as recent as all that, we have children under 5, 35.5% stunted, that is height for age being low. We have 19.3% wasted, that is weight for height being low. And we have 32.1% underweight, that is weight for age being low. Now this certainly has an impact on illness of the child, and the child can easily be susceptible to a variety of infections. There can be death. There can be a loss of cognitive power. Even if these children survive, the precious brain growth which is affected is going to deprive us of cognitive power in a time when we are really preening ourselves on our demographic dividend that will come upon us in the next 2 or 3 decades. If we have a population that has been wasted and stunted and the brain cognitive power depleted because we could not pay attention to their nutritional needs, then certainly we are going to be in trouble. And not only that, it casts a long shadow into adult life and early adult life, with a much higher risk of cardiovascular disease and diabetes coming up in early adulthood. And this relationship is also well proven in Indian studies. But there is also the looming danger of non-communicable diseases like cardiovascular diseases and diabetes and chronic respiratory disease and cancers and mental health, all rising to the fore with much greater speed. In 2018, 63% of our deaths were due to non-communicable diseases, of which cardiovascular diseases were 27%. But again, a huge amount of disability also, apart from death, because of these conditions, especially mental health disorders, but even other disorders. Now, one could argue that perhaps death from a cardiovascular disease or cancer, if one were a cynic, one could argue that the death might be inevitable. It has to come sometime or other, and the non-communicable diseases are a usual way of ending life. But that might be true if it were a full and fulfilled life, maybe in the 9th decade or even older. But in India, 56% of the deaths due to non-communicable diseases occur below 70 years of age. 40% of the deaths occur below 65 years of age. So these are deaths that are occurring in the productive prime of midlife. And it has consequences, not only for the individual, but for the family and for the country. And in terms of economic losses due to productivity losses as well as healthcare costs, it has been estimated by a study from Harvard School of Public Health and the World Economic Forum that India's losses due to non-communicable diseases because of this will amount to $4.58 trillion between 2011 and 2030. And we do have some predilection for certain types of risk factors and diseases, high excess risk of diabetes, oral tobacco leading to a huge amount of oral cancers, and indoor air pollution, the kitchen's curse, which drags women who are cooking with solid biomass fuels, the toddler playing around her and the babe in her arms, all of them likely to be affected in terms of their respiratory disease and even acquiring other diseases as well. But we also know that this is going to increase because we see that urban acculturation actually increases the risk of non-communicable diseases in the absence of appropriate preventive policies. And with increasing urbanization, we are going to be seeing this, and this is something that we have seen in our own research, where within 5 years of migration to an urban environment, urban workers in factories in 3 cities acquired far greater amount of cardiovascular risk and diabetes risk compared to their siblings who stayed behind in their villages. And we also know that as these epidemics of non-communicable diseases advance and mature, the social gradient reverses, first for risk factors, then for events, and the poor will ultimately become the major victims when the mediators of risk like tobacco and unhealthy diets are mass-produced for mass consumption. And that is going to have a major challenge for our health system, which will be unable to cope. And why has India's health system faltered? India's health system has suffered from low public financing for health for several decades. It's not a recent phenomenon. Because health has not been seen as an investment for economic growth. A hangover of a thinking initiated by an American economist called William Baumol, who said health care is a cost disease. With increasing investments, you are not likely to see increasing returns in terms of economic productivity, unlike the industry, agriculture, and service sectors. This has been contested and definitely argued in a number of international reports since, and that's why we have seen ultimately health being recognized as vital to development, and that the bidirectional relationship that exists between economic growth and health is important, because even as economic growth improves the health of the population actually accelerates economic growth. But it has taken a while for our own economists to recognize this. But you can see that being reflected in the amount allocated for health budgets. In India, if you take government health expenditure as a proportion of total health expenditure, India in 2017 was 30%. In Sri Lanka, 56%, China, 59%, Thailand, 78%, UK, 83%. And surprise of surprise, in the United States, which is considered to be the poster child of privatized medical care, government health expenditure as a part of total health expenditure was 48%. Medicare, Medicaid, Veterans Administration, all of that combined. And as a result, out-of-pocket expenditure in India has been extremely high. In 2017, it was 62%. The recent estimates are about 48.5%. But the World Bank, as well as the WHO, recommend that if you want to have universal health coverage, then you need to have your out-of-pocket expenditure restricted to less than 20%, around 15 to 20%. And recently, it does say the National Health Accounts of 2017-18 say that the out-of-pocket expenditure has come down to about 48.8%. But the total health expenditure has fallen from 4.2% of the GDP in 2004 and 5 to 3.3% of the GDP in 2017 to 18. So the actual amount of money being spent on health is actually decreasing, even though the government share may be rising. And why is that so? It is also because out-of-pocket expenditure can fall because of foregone care. If people feel that healthcare is costly and do not access the care they need when they need, then you don't have out-of-pocket expenditure. You can actually lower out-of-pocket expenditure and take pride in it, but actually you're denying people the coverage. So we need other indicators as well. And at the same time, we have a great shortage of our healthcare workers. The WHO estimates that we need 44.5 per 10,000 doctors, nurses, and midwives to achieve universal health coverage and achieve our sustainable development goals by 2030. This is a global prescription. What do we have? If you combine our nurses, midwives, and doctors, on record, we have 25.7 per 10,000. Not too bad. But when we actually adjust for qualifications, are these doctors and nurses who are listed in the census qualified? And we also look at who is actively working now. Are they actually serving in the society? in the functioning or retired or migrated or somewhere else, we have then 4.8 doctors and 5.7 nurses per 10,000. That is a total of 10.5 per 10,000 as opposed to 44.5. So we have a huge problem of numbers, but we also have a huge problem of maldistribution. We know that 2/3 of India's population resides in rural areas, but 2/3 of our health professionals serve in urban areas. And there is a huge disparity between states. Southern states are much better endowed in terms of their resources and even in terms of their medical college seats as compared to central India and northern India and northeastern India. So the physician density is an important element that also distinguishes our states. But when we look at healthcare, we recognize that there are 3 challenges to healthcare. If we ask the question, how best can we deliver healthcare to our patients? The challenges are access, costs, and quality. So in order to address this, the WHO advocated, and the United Nations has adopted in the Sustainable Development Goals, the idea that every country must achieve universal health coverage. Now, there's some debate whether we should call it universal health care or coverage, but we can define coverage to definitely mean care in all of its dimensions. And the WHO defines it as all individuals and communities receive the health services they need without suffering financial hardship. It includes the full spectrum of essential quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care. And this is now part of the Sustainable Development Goals as well. But how do you measure it? Firstly, financial protection. If you're really talking about providing financial protection, has it reduced out-of-pocket expenditure? Has it reduced catastrophic health expenditure? Has it reduced healthcare-related impoverishment? But then, as I said, you can show an artificial reduction in out-of-pocket expenditure by people not accessing services when they need, foregone care. So you also need an indicator for service coverage. So you must have simultaneously an increase in service coverage and a decrease in out-of-pocket expenditure to be on the road to universal health coverage. And for this, a relatively unsatisfactory, but at the moment an interim indicator combining 14 indicators has been developed by the WHO, and that's what's being studied, looking at service coverage in different areas. But then the WHO also recognizes that we cannot achieve this overnight because every country is in a different state of health system development and also different level of resources being available. So it describes 3 dimensions for this. One is in terms of population coverage, how much of the population is covered and by the Universal Health Coverage Program. Second is service coverage, which are the services covered in the package. And third is financial protection, what is the amount of cost coverage so that you're preventing out-of-pocket expenditure being high or poverty related to unaffordable healthcare expenditure. Now the stakeholder perspectives differ in this. The politicians would like to have as much population coverage as possible, partly because they may believe in equity, but mostly because they would like to please the voters, as many voters as possible. Even if the services provided are relatively shallow, they would like to see many more beneficiaries, certainly. The health professionals, the doctors, are people who would like to see as many services included in the package as possible, because I believe what is best, what is needed for my patient has to be provided. The best possible care must be provided, whether it is cardiac transplantation or renal transplantation, or whether it is the most expensive form of chemotherapy or a cochlear implant. I believe as a professional that my patient should get it. So they believe that service package is important. The people who manage the purse strings, sitting in the finance ministry or the health system managers or in the Niti Aayog and other planning commissions or whatever, they look at how best the money can be spent in order to reduce poverty, to reduce out-of-pocket expenditure, while maintaining fiscal prudence so that the budget doesn't go bust. Now, there's a dynamic tension between these three perspectives. At any given time of evolution of universal health coverage, depending upon the availability of resources available, you have to find the right balance. And that balance usually comes from examination of various choices, and the choices are to be made between individual and societal burden of disease measurements, size of the health impact, cost effectiveness, degree of financial risk protection, affordability, what's the fiscal space, equity, attention to vulnerable groups, feasibility of implementing, health system readiness, scope, is it scalable, is it sustainable, and ultimately acceptability, political alignment among stakeholders, and public acceptance. Usually cost effectiveness is used as the measure. The interventions among the various options available, what is the cost effective option? How much health will the money buy? But then there is another element. In addition, how much of financial protection will the money buy? And that brings in what is called extended cost effectiveness to prevent people from being pushed into poverty. But equity is very important as well, and equity needs to be considered in two different dimensions. One is what we can call horizontal equity, in which everybody has access to similar services, primary health care or secondary health care. The package is common to everybody. But there also has to be a vertical dimension of equity, in which you are also seeing pre-existing health equity gaps of vulnerable groups and try and bridge those gaps through your program so that you are doing justice to them by allocation of additional resources or paying for additional services, but definitely you have to recognize that those gaps also exist and you have to find that balance. Now, we also recognize that there is the task of purchasing and providing these services. Usually, we expect that the purchaser will be principally tax-funded government finances, supplemented by government-subsidized social insurance programs, and further added upon by employer-provided insurance and privately purchased insurance. In India, at the moment, we have government-funded health insurance supporting 361 million. In terms of group health insurance, which corporates and other businesses provided for their employees, it is 93 million. That's only 1/5. The government-funded health insurance provides 3/4 of all the insurance. And the rest, which is private, is 43 million. So we are talking about 497 million. What is happening to the rest? They're essentially having to fend for themselves. So that is where we definitely need universal health coverage if we want people to be protected for their health care when they need it most, without having to pay a heavy financial price for it, or without having to forego needed care. But what are the methods of payment? What are the most efficient methods of payment? We are used for long years in this country to what is known as a fee-for-service mode of payment. Every time you go to a doctor, you pay. Every time you get a test, you pay. Every time you get admitted into a hospital, you pay. On the other hand, that actually this creates a perverse incentive for more tests, more requirement of consultations, and more procedures to be done, more hospitalizations, and so on. On the other hand, there is a system called capitation fee model, which is nothing to do with medical college capitation. It means that there is a bundled payment for services that a particular provider is allocated a number of patients, 1,000 or whatever the number may be, and the provider has to provide for all the needed health services of that person throughout the year. Yes, some people will exceed that limit. If let's say, for argument, it's 1,000 rupees, or 10,000 rupees, it will exceed that limit. But many others who are healthy that year do not require those services, will not need it. So the provider will not lose the money. But there is a greater incentive for the provider to keep the people healthy through health promotion, through early detection of conditions like hypertension and diabetes, and treating them effectively before they go in for coronary artery bypass surgery or renal transplantation. Now, that system exists, for example, in the National Health Service in UK. It exists through the Kaiser Permanente system in some of the states in the US. So we have to really look at how best we can achieve some of those balancing elements as we move forward. And for that, we may actually need to bring in the private sector also in a much more responsible manner rather than leave it entirely in a laissez-faire style of operation. So the role of the government is provision through strengthened public sector and contracted private sector where there is need and opportunity. Public financing from tax revenues, principally from the budget and also through social insurance programs. Pooling, to have a single payer system. We ought not to have multiple payers because that is inefficient. On the other hand, with a single payer, you are actually going to have much greater capacity for negotiating a fair bargain from the service provider. And you can actually reduce the price of the care and increase the size of the service package. The Tamil Nadu Medical Systems Corporation, for example, used this method of procurement in order to use what's called the monopsonic power, which is opposite of monopoly power, in order to ensure that they reduce the price of medicines quality by procuring quality assured generics. So purchasing is important. Regulation is also very important of standards, quality, price, ethics, education. All of these areas need regulation. What do we do with the private sector? We have a very large number of our doctors, 80% of our doctors and 70% of our nurses are in the private sector. So we cannot ignore it because our mixed health system has evolved by default rather than by design, but we still have to make the best use of what we have. So we need to bring in the private sector in a much more responsible way. And there, they have shown a reluctance in general, the organized private sector, has shown a reluctance to participate in primary care. We ought to see how best they can actually, if they do come into primary care, to partner with the government in a much more responsible manner, particularly in the implementation of national health programs, whether it's tuberculosis control. No, you can't really think of TB control without the private doctors in practice to whom people go, without being part of that system. So their contribution to national health programs has to become important. Even their providing data on infectious diseases is going to be important. So the private sector has to be brought in a proper manner so that they are regulated and they actually become part of the overall framework without operating with total independence and impunity. Now, in terms of secondary and tertiary care, they are already participating in the Pradhan Mantri Jan Arogya Yojana, but since it is disconnected to primary care, they are only happy to take the money for the government-funded programs for secondary and tertiary care, but they are not really willing to get into primary care where the profits are much less. So you definitely need to see how best you can actually get them to link up in a better manner. And they also can be part of the pooled procurement process, where they can also get the procured drugs and equipment at a lower price through the central procurement process, and they pass on the benefit to the consumer. So there are a number of ways in which we can really look at it. Public-private partnerships have acquired an odium with many of the people in the civil society calling them partnerships for private profit. But if we redefine the scope as partnership for public purpose and define the public purpose very clearly and define the deliverables and accountability mechanisms also very clearly, then we may be able to make better use of the private sector that exists. Of course, all of this requires stewardship and governance, which is much more capable and competent. So, in terms of public financing for health, we need to increase the general tax revenue, not only increasing the tax to GDP ratio, but also improving our tax collection systems. We may have to think in terms of some special taxes on tobacco, alcohol, and unhealthy foods and luxury vehicles, and see whether some of that money can be spent for universal health coverage like Philippines has done, and also at the same time improve allocative and utilization efficiencies, not pump in money into tertiary care, but strengthen primary care and secondary care through district hospitals much better. My former director at the All India Institute of Medical Sciences, late Ramalingaswamy, said something which has actually been repeated by many others later on, but without attribution properly, but he was the first one to say it in an international report, that we need more money for health and more health for the money. So we need to spend it better as well. But for this, we need to revitalize our primary healthcare services. We need to invest more in rural and urban primary healthcare services, strengthen our sub-centers with technology-enabled frontline non-physician healthcare providers, convert static facilities into nearer-to-home outreach facilities, improve physical and IT connectivity between sub-centers, primary health centers, community health centers, and district hospitals, improve referral and follow-up systems, promote integrated care through networks of providers, and enhance community participation and monitoring. So I would say that we did try some of this through the National Rural Health Mission and the Rashtriya Swasthya Bima Yojana, but because of the limited scope of services and limited financing available, it did not proceed very well, though well-intentioned. The benefits were limited. So in 2011, when the Planning Commission asked us to come up with a plan for making key recommendations for universal health coverage, we said, commit at least 2.5% of the GDP as public financing for health immediately and then raise it later on. Prioritize primary health care for financing and human resource development and deployment. Conduct a review of all government-funded programs, central and state, and merge them into a single pool. Provide essential drugs free of cost, because 70% of out-of-pocket expenditure is outpatient care, and 70% of that is on drugs. So if you can provide quality-assured generic drugs free of cost, essential drugs, then you're going to make an immediate impact on reducing out-of-pocket expenditure. And establish credible and effective regulatory systems and enable active community participation. Now, some of these have happened. Ayushman Bharat has brought in some components of this in terms of comprehensive primary health care through health and wellness centers. National Health Protection Mission also acquired the name of Pradhan Mantri Jan Arogya Yojana. But these are relatively piecemeal. More importantly, there are disconnects. Primary care, secondary care, and tertiary care are not connected in a harmonious, seamless fashion. So we need to remove these disconnects, and we need to create a coherent healthcare system which can provide care at all levels. And the 15th Finance Commission has done us a service by emphasizing the need for primary care, urban health, disease surveillance, critical care centers, allied health workforce training, many of which were gaps earlier. I think COVID brought these needs very much into focus, and I think some of the recommendations of the 15th Finance Commission have been reflected in the union budgets of 2021 and 2022, and we now have new schemes called Pradhan Mantri Ayushman Bharat, Health Infrastructure Mission, and the Digital Health Mission. So let me step away a little now in terms of my concluding segment, which is that health, this is a quote from Gunnar Myrdal, a Swedish economist, Nobel laureate of 1974. Quote, health leaps out of science and draws nourishment from the totality of society. So we recognize that the determinants of health lie mostly outside of the health sector. While health sector is absolutely important, there is health beyond health care, which needs to be addressed. And if we take health financing, if we take three circles, in the innermost circle is health financing, which comes from tax and social insurance and other forms of insurance. But in order to make it into universal health coverage, you need a functioning health system. with a health workforce, infrastructure, governance, drugs, vaccines, and technologies, community engagement, health management information systems. If you combine those two circles, you get universal health coverage, but still you don't get a healthy society. You still need an outer circle of social determinants of health, those which operate at the broader societal level: water, sanitation, food systems, physical environment, social stability, and those that operate at the individual level but are propelled by social forces. A person's education, occupation, income, gender, social support networks. You can have inequalities in every level, in every form, and unless you address those, you'll never be able to create a healthy society. A British economist of the early 20th century, R.H. Tawney, said, "It's not just enough to provide equality of opportunity. What we need is an equal start, not just an open road." He described equality of opportunity as decorous drapery. Unless you actually influence the social determinants of health so that a child has good nutrition from not only birth, but from the prenatal period of her mother, from the time the mother was a girl child, unless you make sure that the various forms of discrimination are removed from society, you will continue to have difficulties even if you provide equality of opportunities. And for a girl child, many of these are epigenetically modified. The social forces act upon, and physical environmental forces act upon how the genes are expressed, not only in one generation, but sometimes across multiple generations. If a woman who is pregnant is undernourished, the girl baby in her womb will be undernourished and born susceptible to a variety of health conditions. But that girl baby has eggs in her. Those two would have been epigenetically influenced, so that not only the child yet to be born, but the child yet to be conceived also is affected. So multiple generations can be affected. So we have to address all these determinants if you have to create a healthy society. You have to recognize inequality in all its forms and then try and correct them, and not just depend upon hospitals for delivering health care, though they too are necessary. But to close finally, and just let me give you an example of how the social determinants are very vital. It is very clear that, as I said, there's a bidirectional relationship, even at the population level. As the economic development increases at the population, the health status reflected by life expectancy also increases. And this happens fairly steeply when the economic development is at a relatively low level. But by the time you reach $5,000 per capita, it's sort of plateaus off. The incremental benefits are much lower. But at any given level of economic development, even amongst the rich countries, those that benefit best in terms of health as well as other social indicators are those that have the lowest level of inequality in the population. Among all the OECD countries, the United States lags behind in life expectancy and other social indicators. And you just have to compare Japan and the United States and you see the gap. Therefore, countries must not only focus on economic development, but also ensure that there is equality, that the income gaps and other social gaps are not wide and awning, if you want to get the best in terms of health benefits, if you want to create a healthy society. And that's important. And this is something that has been pointed out by Wilkinson and Prickett in their book Spirit Level, and it's been shown very clearly. Now, for example, the US spends 18% of its GDP on health, whereas other OECD countries spend about 2/3 or half of that, but all of them have higher life expectancy. Now, climate change. With Vandanaji there in the audience, I cannot but talk about climate change and food systems and agriculture. We know that as climate change accelerates, we are going to see a huge amount of health effects, vector-borne diseases, as humans in increasing temperatures will wilt and lie listless in the soaring temperatures. The mosquitoes will get athletic and climb to higher altitudes. They'll spread farther and faster. And you'll see many more mosquito-borne diseases like malaria, dengue, chikungunya, and other diseases spreading much more. You see severe heat effects. You see extreme weather effects, floods and famine, all of them. And on food and agriculture systems, just to close on that, for every 1 degree rise in 1 degree centigrade rise in temperature in South Asia and Sub-Saharan Africa, there'll be a 10% decrease in the yield of staples. And we are already operating at a very high level in terms of our temperature vulnerability for our staples in India and in South Asia and in Sub-Saharan Africa. But the quality of food also will decrease. There will be a reduction in the zinc, iron, and protein content of these staples. And the Data Science Institute of Columbia University has forecast that by 2050, if climate change continues the way it is, India's agricultural system will have serious challenges, and we will be creating 49.6 million new zinc deficient persons, 38.2 million new iron deficient persons, 106 million children, and 396 million women will be iron deficient, only by climate change. And they have said that if you actually change your systems to more climate resilient, but also more water efficient, resource efficient crops like millets and sorghum, you may be able to forestall some of this. So let me conclude by saying that never before in human history have we been so forewarned of the disaster that might await us. But never before in human history have we been so forearmed with the knowledge and tools to alter that destiny. It is a challenge to human intellect and enterprise as to how best we respond to this challenge with social solidarity and global solidarity, but also with a commitment that we shall move on the right path to ameliorate all forms of inequality. And here we need the media to take the lead, and we in the public health community are ready to partner. Thank you very much.
Thank you so much, Dr. Reddy. That was so comprehensive, and it's what struck me sitting there and listening to you was, you know, the kind of contiguous arguments of Arafa in her stories and what you are saying about inequity. Unless we address that, we're getting nowhere, and the falling health expenditure, unfortunately, will just ensure that we keep on floundering when it comes to any public health emergency in this country. I believe we have about 4 or 5 minutes for any questions from the audience to Dr. Reddy. There's a mic which is going around, which can come to you. Do we have any question? There's a gentleman there in the pink shirt, yes.
Yes, my name is Suman Berry, and my question is to link up what Dr. Reddy had to say with the awardee. So, you know, India has had one of the largest and earliest interventions for maternal nutrition, early childhood development, and yet the outcomes in terms of maternal health, stunting, etc., are the way you painted them. So do you draw the link between, as it were, the treatment of the Anganwadi workers that our awardee has illustrated and these poor outcomes? The larger question is, we have the programs, but we don't have the outcomes. So where's the spark missing? Why are we so much behind our peers in Sri Lanka? And secondly, the point that you made, what is it that Madhya Pradesh should be learning from Kerala on how to, as it were, narrow the gap between input and output?
Yes.
Nutritional programs are helpful, but firstly, they have to provide balanced nutrition. That's not always been the case. Look at Madhya Pradesh, for example. They've again gone back and banned eggs. So you have to make sure that your programs are actually well structured and not necessarily being driven by some ideological prejudices. Secondly, you have to make sure that whatever is actually being supplied is being properly delivered and is reaching the intended beneficiary. There are many leaks along the way as well. Third, some degree of supplemental nutrition helps, but it cannot really take away from the poor nutrition which the family is forced to suffer because of a poor economic constraint. We know, for example, the NREGA has actually improved nutritional status wherever it functioned well. So there are some lessons that we have to learn, how to enhance the income level of the family as well, at the same time while providing supplemental nutrition wherever you can in the most efficient manner, but try and provide the most balanced nutrition as well. That is also going to be an important element. So these are some of the things that we ought to look at. But there are also other challenges. We need what are called nutrition-sensitive measures. If you don't have proper water and sanitation, then if the child is going to get diarrheal diseases, the nutrition is not going to be retained. So there has to be a multi-pronged effort, both nutrition-sensitive and to some extent nutrition-specific. I would say that's important. As far as what Madhya Pradesh has to learn, I think Madhya Pradesh has to learn, first of all, multiple things. For example, the whole idea of how Kerala has done well is because of the strength it has in women's literacy, women's participation in the workforce, the whole social structure. But as an immediate measure, I would say they must double the number of their ashas and auxiliary nurse midwives. That will provide much greater employment to women as well, enhance their capacity. We cannot produce doctors very fast, so at least the frontline health workers who can be recruited, trained, technology enabled, they can actually enhance the frontline health workforce very fast. But taking a broader element, when people ask me, what is your prescription for India's health in terms of various states? My simple or rather simplistic answer is, if every state had the social determinants of Kerala and the health system of Tamil Nadu, we'd all be in a better place.
Thank you so much. I think there's one question, and I'm afraid that will have to be the last. If you can make your question quick, yeah. Short, please.
I would just like to know what is the percentage of population which is suffering from NCDs, non-communicable diseases in the country, number one. Number two, how much GDP is lowered due to NCDs in the country? And ultimately...
Okay, I will not allow you a number 3, sorry. Okay, Dr. Reddy, please.
Just fleeting question, anyhow.
We just have to, yeah.
Anyhow. And it is just a very common adage that health of the nation is more important than the wealth of the nation. No? That also you must propagate. No?
Sorry. As far as the prevalence of NCDs is concerned, there are difficulties in estimating the numbers accurately because our surveys have not been comprehensive. They have been relatively piecemeal, though some ICMR studies have been done which have attempted to capture. And NCDs are a broad bucket. They include cardiovascular disease, which also includes hypertension. They include diabetes, they include chronic lung disease. You have prevalence estimates for all of them separately. Just to give you an example, hypertension prevalence in urban areas is anywhere between 27 to 30% among adults. Diabetes prevalence is very variable across the country. In cities like Chennai, it's upward of 20% in measured diabetes. Probably close to 24% now, whereas in other parts it's lower, rural areas it's lower. But you'd be shocked to hear a statistic that has been produced by a survey of Chennai and Delhi, and Professor Nikhil Tandon from All India Institute of Medical Sciences some over 6 years ago. The survey in Delhi, which includes all criteria for diagnosing diabetes and all criteria for diagnosing pre-diabetes, various criteria. If you add all of them, 78% of Delhi's population, adult population, is either pre-diabetic or diabetic. Now, you have to be shocked at that.
A lot of your utterances, Dr. Reddy, have been really headline-grabbing, and I'm afraid of, for your truth-telling, and I hope that you don't get the Pegasus in your phone. Thank you so much. Thank you for all that wonderful presentation. I'm afraid we have come to the end of the program. We've got 3 minutes to 8. And this is the time where I must thank all the people who've been here. First of all, Dr. Reddy, Arifa for having, been here and made us all believe in journalism again. Every year we do that. IIC for always supporting us and giving us this wonderful venue, and we were dying to come back in person. Mr. Srivastav, the director, who's, I think, left, program division, headed by Tete, who's always so supportive. Devaki, is Devaki here? Devaki for her generosity. The 3-member jury of the Chameli Devi Awards. Nirupama Subramaniam from the Indian Express, writer Geeta Hariharan, and Ashutosh from Satya Hindi. The PHFI team and the Media Foundation team, especially Shailaja Bajpai, Shuma Raha, Rajiv Mehrotra, and all the others who work tirelessly, including Manika Chopra, who hasn't put her name in here. Okay. Thank you all for being here, and hope to see you again next year. Thank you.